equipment. Just as a reminder, please make sure that you use the Q&A box only for the questions. And then if you have any comments, you can use our chat box. And also just to highlight that for those that are raising their hands, we won't be able to allow you to get to speak, but please, if there are questions, direct them to the question and answer box, or if it's a comment on the chat box. And for additional resources, please make use of our different websites. That is the Africa CDC, the ICAN, WHO, and Resolve to Save Life websites, where you can have in-depth resources on IPC issues. We will provide a certificate at the end of the 6 weeks. That is for each series. Each series has 6 weeks. And for you to be able to attain a certificate, you have to be able to attend at least a minimum of 4 sessions out of the total of 6. And also ensure that you attend for more than 60 minutes out of the 90-minute session. The recordings and the talks will be emailed to you using the email that you used to register. And we'll also encourage you to join the community of practice, and the link will be provided in the chat box. There's also, we're currently running the Portuguese and the Arabic interpretations at the same time. So without wasting so much time, we're going to invite our first speaker, who is Dr. Ario from Africa CDC. Dr. Ario is an IPC expert. She has more than 10 years experience in IPC. He serves as the IPC focal person for the Southern African region, where he coordinates IPC activities. He is also a member of the Africa Task Force for Novel Coronavirus, IPC Technical Working Group. He holds a master's in public health and a PhD in environmental and public health from Salford University, UK. His team in Africa CDC has developed more than 15 IPC guideline documents, including standard operating procedures. In the year 2014, he won the Time Magazine Person of the Year Award alongside other Ebola responders, and he holds various awards. He has also received many commendation letters, including the one from the UK Prime Minister David Cameron in 2012. So Dr. Ario, over to you for the EPI updates. Thank you.
Thank you, Lizzie. Let me quickly share my slide. Thank you so much, Lizzie. The panelists, our distinguished participants, ladies and gentlemen, good morning, good afternoon, and good evening, wherever you are. I will take you through the epidemiological situation of COVID-19 as of this morning. This is the global situation. The map by the left shows the number of COVID-19 cases that have been reported. The darkest part of the map shows those that have reported more than 1 million cases. And the less it is how it comes down. And when you look at the left side, when you look at the right side, you see the map there, the graph there is showing the new COVID-19 cases reported daily from 9th January up to 12th February. And you can see that some of them, they are coming down concerning the number of cases reported daily. This is the situation in Africa as of today, as I said. This is the EPID curve for the continent. And we can see a downward trend in the curve. This is not showing. This is not that the cases are going down. We have noticed also the reduction in tests conducted per day. So that might affect this downward trend. It doesn't mean that the COVID-19 is really going down as we see the curve. So the rate at which people conduct COVID-19 tests is reducing, but at the moment, 3.7 million 3.7 million cases have been reported in Africa, while we have more than 99,000 deaths, which gives 2.6% case fatality rate. And at the moment, 88% of the COVID-19 patients have recovered, which gives about 3.3 million. This is the cumulative COVID-19 cases by AU member states. So we have one country that is reporting that has reported more than 1.4 million cases. So we have 23 countries that have reported between 10,000 and 100,000 cases. We have 8 countries that have reported between 100,000 and 500,000 cases. We have 22 countries that have reported between 41 to 10,000 cases. So one country doesn't recognize that COVID-19 exists. They are not reporting. Our COVID-19 situation by AU region shows in this table. We can see the Central Africa has reported about 3.7 million cases, and the total deaths is about 99,000, which gives a case fatality rate of 2.6%. So the Southern Africa is the highest for now, followed by the Northern region. This is the situation as of today. The new COVID-19 cases reported per 1 million population per day for AU member states. We have one country that is reporting 100 cases per 1 million population. We have 7 countries that is reporting 50 to 100 cases per 1 million population. 22 countries are between 5 to 50 cases per 1 million population per day, while we have 20 countries reporting between 5 cases per 1 million population per day. Those are the ones we have in green color. Those ones in red are those ones reporting between 50 to 100 cases per 1 million population per day. So this is a map showing the case fatality rate for all the 55 member countries, except the only one that is not reporting. So we have 3 member states reporting more than 5% case fatality rate. We have 18 countries reporting between 2.2 to 5% case fatality rate. 23 countries are between 1 to 2.2 CFR, and 10 member states are less than 1% case fatality rate, and those are the ones in green. This is a graph showing the number of tests conducted in Africa. More than 33 million tests have been conducted on the continent. 8.8 test positivity rate is 11.3%, while we have 8.8 tests per reported case. Okay, instead of WHO has suggested we should be testing between 10,000 to 30,000, between 10 and 30 tests per case. When we have a case, we should be testing between 10 to 30 per case. But now we're at 8.8 at the moment. So as I said before, the number of tests conducted in Africa is also reducing, as you see, downward trend here on the graph. That is what I have for now. Over to you, Lizzie.
Thank you, Dr. Ario, for the updates. As we can see that we still have to be on guard and the war is far from being over. I'm going to invite our next speaker, who is going to give us a talk about the multimodal strategy for use and reuse of personal protective equipment. She is Professor Shade Ogunsula. She's a professor of clinical microbiology and is the ICANN chairperson. She has for 2 decades been involved in infection prevention control in Nigeria, the whole of Africa and beyond. She was the founding member of the Nigerian Society of Infection Control, and she assisted in setting up the infection control programs in institutions around Nigeria. She's the Vice Chancellor of the University of Lagos, and she is also a member of the Global Infection Prevention and Control Network. She's presently on the government think tank for COVID-19 in Nigeria and also on the African Task Force for the novel coronavirus, where she serves on the guidelines, training, and research committees. Over to you, Prof.
Thank you very much. I'd like to welcome you, and we have today a trial. We will be looking at PPE slightly differently from how we did it before, which is how do we set it up and ensure that we have enough. We'll look at it from facility level, we'll look at it at the national level, and then we also bring for you someone who has had experience in changing minds. So let me remind us that when we know the methods in which a disease is transmitted, then we know how to implement proper infection prevention and control and be able to have large-scale prevention campaigns. And each disease has its own transmission characteristics based on the nature of the microorganism that causes it. And this really speaks to IPC. We need to know the organism, we need to know how it's transmitted so that we can have the right prevention methods against it. So let me just ask, and can people just put this in their boxes? These were familiar sites during the COVID-19 pandemic. What do you think about these people? Can I have some impressions from the chat box? Lizzie, can you help me to sort of read out some of these? Okay, I can see, I can.
All right, there's overreaction, disinfecting, spraying is not pointed anymore, PPE overkill, total protection head to toe, there's creation of panic and fear, masks, they are well protected, so they are overdressed. The prevention starts with yourself. Thank you.
Thank you. These are relics from the Ebola epidemic. And this was a major problem at the beginning of this pandemic, and still a problem in many places. There is PPE overkill. I agree with you. Yes, they're properly masked. And again, this speaks to our attitude in terms of we continued with what we're doing with Ebola without thinking about what kind of organism we're dealing with now. So this is a Ebola, but it had real problems. You have all these people wearing PPE. I mean, there were others of guards in people manning the gates in hospitals who were in full-blown PPE. But it translated to a lack of PPE, a shortage of personal protective equipment as well. We had the large number of patients, but we also had a lot of people wearing PPE that they did not need. So we had this huge shortage of PPE, and we still have quite a bit of it because of the problems of the large number of people who are ill. So today we'll talk a little bit more about, PPE, and just to remind us how SARS-CoV-2 is transmitted. It's by inhalation of droplets that are expelled from infected persons' respiratory tract through coughing, sneezing, talking in close proximity. So you have to have contact with patients' respiratory secretions, and sometimes that also happens indirectly through the hands that touch contaminated surfaces. So when droplets are expelled, some drop on horizontal surfaces, and then we contaminate our hands and can take that to our face. And then in certain situations in hospital, when you have aerosol generating procedures, you have these aerosols persisting in the environment and in much smaller, smaller particles, and they can be inhaled directly. And also in the community, we have certain situations that seem to create a sense when the droplets are airborne for some periods, especially when we're using air conditioners in closed spaces where there's no ventilation or very poor ventilation. So on that note, so let me just remind us of our PPEs and what they're supposed to do. PPEs for facial protection include the medical mask and ones for eye protection, face shields or goggles. They protect the conjunctivae and the mucous membranes of the nose, eyes, and mouth during activities that are likely to generate splashes or sprays of blood, body fluids, secretions, or excretions. Face shields or goggles, in addition, when providing care in close contact with the patient with respiratory symptoms, protect us from direct sprays of secretions. They do not protect your airways in the sense that air breathing, you can still breathe in the air around. So if the nose is not covered, the face shield does not protect you. Gloves, we wear gloves to protect our skin from blood and body fluid exposure. And if there will be contact with mucous membranes or non-intact skin, we need to wear gloves. And you must change your gloves between tasks and procedures, even on the same patient, if you have had contact with potentially infectious material. And you remove your gloves after use and before touching non-contaminated items and surfaces, and before going to another patient to prevent transmission. And anytime you take off your gloves, you must do a hand hygiene. We have gowns and aprons. We also have coveralls, and I have put an X over that because during this COVID era, we really don't need the coverall. And this is to protect our skin and prevent soiling of clothing during activities that are likely to generate splashes or sprays. And we use a ground that is appropriate for the activity and the amount of fluid likely to be encountered. If the gown is not fluid resistant, we must wear a waterproof apron if splashing or spraying of body fluids may occur. And when we remove our soiled gowns, which we must do as soon as possible, then we place it in the waste if it's disposable, or in a laundry receptacle if it's a reused one. And again, you must perform your hand hygiene. I have put this cross here because this is an item we use very often for Ebola. Part of that is because the organism can pass through cuts in the skin. So we're protecting the whole surface of the skin. The respiratory infections do not pass through the skin, so you do not need this kind of cover-up.
They said they need the oats for them to.
Hello? Now, just to remind us about the hierarchy of controls for COVID-19, you must have the right policies in place that speak to how we do things, social distancing, etc. Then we must have the environmental controls that take care of ventilation as well as cleaning of our environment, and then PPE. So when we use PPE, it must be in the context of all the other controls. So it's in addition to other controls. It is never alone. So just another little question, which Lizzie will look at. Which part of the chain do we think the mask primarily breaks? Please put this in the chat box or in the chat box. Lizzie, can you read out some of these for me?
Okay, some of the answers coming in, it's mode of transmission, exit portal, mode of transmission also, portal of entry, mostly a mode of transmission. Some are saying infectious agent, exit and entry.
Thank you very much. The primary place it works on is the portal of entry and the portal of exit, but it does affect everywhere else. If it does not come out of the respiratory tract, then it's not likely to infect surfaces. So if we can keep those, and then if the portal of entry is also covered and protected, then it's not likely to enter into the portal of entry, but it does affect the mode of transmission, because if we are not contaminating surfaces, then we're not going to transmit it as well. So that's another way of transmitting it. So thank you very much. So let's go on. So the choice of PPE, therefore, is always based on a risk assessment. And you assess your risk and you determine this risk by the mode of transmission of the organism. How is it transmitted? Is it airborne, droplet, contact? And by the risk of exposure of the person. What's the type of activity being performed? Where is the setting? Is it in a closed space? Is it in a well-ventilated area? And the person, how susceptible is the person? You know, what are the person's comorbidities and so on? So is that person adequately protected, dressed? So all these, is the mode of the person's comorbidities and susceptibility also comes into place. So healthcare workers at every point must routinely assess their risk of exposure to body substances or contaminated surfaces before any anticipated healthcare activity. So when you know the mode of transmission, you must be thinking, how am I exposed? What are the things that I am doing? And you select your PPE based on your evaluation of the transmission risk and your level of exposure. So health managers need to ensure that appropriate PPE is available at all times so that it can be used in the event of an unexpected emergency, so that when healthcare workers are evaluating, they have the right PPE at the point of care. So according to level of care and risk, we have here for triage, really, what you need is hand hygiene, a medical mask, and plenty of social distancing. And you can also have a barrier between you so that you don't have to use a lot of PPE. Collection of specimens for the laboratory, where you're going to move closer to the patient. Then hand hygiene is important. Your gown is important. You need to have your respirator, the N95 or FFP2 or 3. And then you should cover your face because you're going to move close to the patient. And then, of course, you need your gloves. Now, when you have a suspected or confirmed case of COVID-19 requiring healthcare facility admission, but that person is not going to have any aerosol generating procedure, then hand hygiene, your gown, your medical mask, your goggles, and your gloves. And of course, where possible, you do physical distancing. And if the person is suspected or confirmed, and there is going to be aerosol generating procedure, then you must have an N95 in addition. So what are the strategies that you should have to promote appropriate use of PPE? using multimodal thinking. And multimodal thinking is that you want people to change their behavior. You want them to do the same thing and make it a habit. For you to do that, we do know that there's certain things that go along the behavior change pathway that assist people to do what they need to do regularly. And that is one, you've got to build it, which is a system change. In other words, if you want me to do something, then you better provide the resources for me to do it. So if you want me to change, to use particular PPE, it has to be available. Otherwise, why tell me to use it? Then you've got to teach me how to use it. What are the things I need to know so that I can use it appropriately and properly? And then you need, as the manager or the person in charge, to ensure that I'm doing this the right way all the time. And so you've got to keep checking and evaluating and seeing how you can help to make me do it better each time, checking all those gaps. And then you've got to remind me. We know as human beings that if we're taught something, if we've been given something to do, sometimes we forget. So at the point of these care, we should have things that remind us how to do it. We also must have ways of communicating with our management when things go wrong, so that clearly we're always in that loop of reminding, checking, selling, and creating awareness around this. And then we have to live it, which means we have to sustain that change in our healthcare facility. There's no point doing it only when there are epidemics. What happens in between epidemics? Because it's what we do in between epidemics that speak to how well prepared we are for the next epidemic. And it's very clear that we're going to be seeing a lot more epidemics as the world population increases, climate change is increasing, we're moving into ecosystems, and then the world is a much smaller place. So in terms of building, you have to ensure that there's supply of PPE at the point of care. It means you have to watch your stocks. You have to plan your stocks. You already know how many, you have an idea of the patients you see, you have an idea of the turnover of all your patients. So these things should be planned using all these methodologies. You need to maintain your supply chains and even look for new ones, especially in this period where there's a shortage worldwide. What many people are doing is working together so that as a country, for example, we're working together to apply for PPE so that we're not pushing the price of PPE up, which was something that we saw at the beginning of this epidemic. We have to optimize use, meaning those who use PPE must need the PPE and they must use it appropriately. And then, of course, PPE has to be properly stored so that it's not contaminated. And then we have to teach our staff. They have to understand the basics of IPC. They have to understand standard precautions and transmission-based precautions. What kind of PPE do you use for contact precautions? What type do you use for droplets? What type do you use for airborne precautions? And what are the other things you must combine with them? And then they must understand the chain of transmission, because then it tells them what areas really need to be protected, what this PPE is doing, and what all the measures we're doing help. Then the WHO 5 moments of hand hygiene, because the hands are a major means of transmitting the organism from contaminated surfaces. So they must understand that so that they're not transmitting. And of course, how to wear and take off PPE without being infected. And then how to deal with stockouts. What do we do when things go out? What are the things we can do to improvise when there's stockout? And then we've got to check it. We've got to use checklists to look at what our people are doing. We have to do observations to see how they are doing. And there are tools that we can use. Sorry, can you keep your voice down? Thank you. And then reminders in the workplace, showing the type of PPE required for activities, how to doff and don, on hand hygiene, on environmental cleaning, on physical distancing, having the signages everywhere so that people can follow easily. All these things help. And then living it. We have to provide the funding. We have to work with staff so that they feel they have a sense of buy-in. We have to prefer solutions to problems. We have to lead by example. We have to motivate, we have to reward those doing well, and there must be some consequences also for people not doing. In other words, the management of the hospitals need to be really in charge. They have to be the champions for appropriate use of PPE and staff welfare. When staff are motivated, when they believe that the hospital cares, they're more likely to listen and work with management in making sure that we optimize the use of our PPE. Now, no matter how well we do it, there will be issues. COVID-19 has created a lot of tension and a lot of problems with PPE and created shortages, even in countries where we never thought they could have shortage. I mean, on the African continent, we're used to shortages. But how do we optimize the use? How do we make sure that the little that we have can stretch? The first thing is, not every patient needs to come to hospital. Are there ways we can, book appointments and discuss things over the telephone? Can we talk with some of our patients? Or can we create barriers in our health facilities so that we don't have to, for example, we're screening, you don't have to touch them. Can we create barriers that extend over our heads and then can we have observational windows, transparent curtains in critical care settings that help to prevent the transmission of droplets and things? What are these barriers that we can have that will limit the need for us to use PPE? Then when we have COVID-19 patients, can we cohort them? Well, in cohorting them, we have to be sure they have no other infectious diseases that they can transmit and have dedicated healthcare workers who can work for extended periods, meaning they don't need to go in and out and change PPE each time they go in and out, so that we streamline this workflow and reduce the pressure on PPE. We could also do simple things, which doesn't require money. For example, if we're going in to do the vital signs, we might as well do vital signs at the same time we're doing, as we're giving them their medication, so that we don't come in, do vital signs, leave, change PPE, then come back in and do that. Or the healthcare workers that are doing the vital signs at the same time can also bring in the food. So it's brought in, dropped outside, and they take it in for the patient to use. So there are little things that we can do that can reduce the numbers of people requiring PPE. Then, of course, as an institution, it must become routine, and we must have the signs and the kind of questions people ask so that they can assess their risk, so that risk assessment becomes routine in selecting our PPE. And of course, we have to check it. We have to remind them the questions to ask. What kind of patient am I seeing? The first thing really is, do I really have to see this patient face to face? If I don't, can I see him in another way so that I don't even have to do a PPE at all? And if I can't, is there a way I can do it as a physical distance so that I don't have to use the full PPE? And those are the kind of questions we need to keep asking ourselves. The hospital can also, in this period of COVID, and we now know that Ebola has started again in South, we've seen cases in West Africa. Do we have any stockpiles anywhere that we keep a little bit for emergencies? A little bit of stockpiles. How do we manage our inventory? And that has to become something that we do with our infection control personnel, so that we actually plan for surges, we plan for stockouts, so that we are never totally off. Those are things we really need to start doing intentionally for PPE. And of course, forecasting what's going to happen and start planning a long time ahead for epidemics. As I said, Ebola is already knocking at the door. So we need to start planning. What kind of PPE will we need? Now, in addition, one more area where we have no choice is extended use of PPE. It means when we say extended use, which is what we prefer to reusing, is that you using any PPE item for longer periods than we normally would. And it refers to wearing the same PPE for multiple patient encounters. Now, this can only be undertaken when there's severe shortages of PPE. And you need to evaluate each time the risk of transmission in that particular context. In other words, it's not a one-size-fits-all. So when you're doing that, you have to evaluate your patients. For example, you can do it when you're providing continuous care or assessment to a cohort of patients with confirmed COVID-19 who don't have or are not incubating or have confirmed other transmissible infections, then again, the other way we can work is to use PPEs beyond their expiration date, provided that we check that they're still in good condition. For example, if you have an expired respirator N95, you need to check that it's not moist, it's not contaminated, that the straps are in good condition, that there's no evidence of tears or damage, and if it will pass the self-fit or seal check. In other words, it's covering the face very well. So there will be other examples. And so these are sort of things that we can use. And I have here, we can get some of these at the end of this lecture. There's a whole WHO document that talks to this. So in summary, PPE should be used appropriately based on risk assessment, which is dependent on the mode of transmission and the exposure risk. PPE must always be used within a package of controls. You don't use PPE alone and ignore the other controls. Healthcare managers should ensure adequate supplies of PPE by planning their inventory to avoid or minimize stockout, and providing the right policies and guidelines, putting in place the right administrative and engineering controls to critical shortages and stockouts. And finally, healthcare managers need to be the champions for all this, motivating their staff and letting them appreciate and making sure that all these changes are sustainable. So thank you very much.
Thank you, Prof. Shade, for that informative session. I'm going to invite our next speaker, who is Dr. Tochi Oko. Dr. Tochi is a consultant public health physician with over 20 years of experience in the field of public health. She's the program coordinator of the Antimicrobial Resistance and Infection Prevention and Control in Nigeria, CDC. She chairs the Nigeria AMR Coordination Committee and also co-chairs the IPC pillar at the Africa CDC Regional Task Force for COVID-19. She serves as a pillar lead of the IPC pillar of the Technical Working Group Force in the Presidential Task Force. She contributes a lot towards health systems strengthening, towards AMR and IPC, and leads major initiatives in addressing preventive measures amongst healthcare workers. She was the co-investigator and program manager in developing a diploma training program in IPC, a first of its kind in Nigeria. She has conducted research and has several publications in local and international peer-reviewed journals. And she also serves as a principal investigator for several ongoing international research collaborations. She is a member of the Association for Professionals in Infection Control and also an ICANN member. Dr. Tochi, over to you. Thank you.
Thank you, Lizzie, and good afternoon, colleagues. So following up from where Prof stopped, I'll be discussing with us some practical considerations for personal protective equipment, discussing things like stock and plans for supply, cost analysis, and what have you. So, sorry, I'm trying to, can you see my slides, please? Okay, so personal protective equipment, like has been discussed earlier.
Les équipements de protection personnelle,
Only one measure within a
comme on l'a dit, ce n'est qu'une mesure dans un ensemble de mesures administratives.
Controls. And if we look at this figure where we see the hierarchy of controls, we can actually see that personal protective equipment is almost an action of last resort. And it's, in the scheme of things, the least effective because it depends on a
Donc,
lot of things.
les équipements de
It
protection personnelle, c'est ce qui est de
the
moins
worker,
efficace
but
parce
the
que
efficacy and how effective it is usually will
il
depend
protège le
on how
travailleur,
well
mais l'efficacité
the
dépend de la
health
manière
worker
dont
understands the use,
l'agent de
how the health worker
santé
is able to use it.
l'utilise, sa
So
compréhension
we usually would love
Sorry,
that.
de l'utilisation.
Yeah. Hello,
Hi,
sorry, something
Tochi.
is going on. Yeah, I can hear the
Yes, please.
interpreter, and it's
Yes. Please, interpreter Annie, unfortunately, we can hear you over the speaker. So please, either you unmute yourself or you follow up with the backend colleagues to be sure that you have been assigned correctly. Please mute yourself so that we can hear the speaker. Thank you. Over to you, Tochi.
Thank you, Wande, for that. So just to summarize this and say that, yes, personal protective equipment are important, but they're not used alone. They're used as a package. We must think about eliminating what can be eliminated, what can be substituted, engineering controls around ventilation, patient placement, and all that, and all the administrative control things that Prof has discussed earlier. And PPE really remains one more tool in our arsenal. But having said that, PPE is still a very important aspect in the COVID-19 control, because the availability of these personal protective equipment, their proper and consistent use is crucial in combating any infectious disease in a crisis. Yes, we can't eliminate everything. We can't substitute everything. Yes, while we can put up some administrative controls, there are still those situations where a healthcare worker must come in close contact and therefore runs the risk, in spite of all the other things we've put in the hierarchy of control, runs the risk of coming in contact with something that comes out of a patient. Point, personal protective equipment remains very important. And then access to personal protective equipment is usually of key concern in healthcare worker safety. And doctors and nurses must use proper PPE while examining patients. For instance, in triaging points, when we're treating patients in intensive care units. There are those moments where health workers must use appropriate personal protective equipment. And under those circumstances, when there's shortage of this personal protective equipment, it poses a challenge and usually will be a cause of stress among healthcare workers. You notice that PPE challenges will result in fear, it will result in decreased confidence and decreased willingness to work among frontline health workers. So yes, personal protective equipment are very, very important. But you notice that during this pandemic, yes, we really all noticed that there was global shortage of personal protective equipment. And some of the things that were found that caused this global shortage, among others, include a low buffer stock. Most countries, especially in our own part of the world, started from a very poor place. We really didn't have good stockpiling already. So there wasn't even for routine services, the stocks were already inadequate. So there was lack of preparedness and processes to quickly procure personal protective equipment at facilities. So many facilities really, so many health facilities didn't have functional infection prevention and control program, and therefore there was no budgeting for personal protective equipment, no budgeting for infection prevention and control materials. They didn't have a way of calculating things like burn rates, utilization patterns, really no system for procurement of personal protective equipment and other IPC items. And therefore, under the situations of a sudden, unexpected increase, it put the system under stress. Added on to that was panic buying by the general public. All this contributed to shortages. We saw people who are not involved in healthcare buying coveralls, gowns, aprons, gloves, and therefore putting the system under pressure. And then there was also the misuse or the inappropriate use of personal protective equipment, and all these things added to the shortage that was experienced in the system. As part of the response activities, we had to come up with guidelines that became very relevant, not just the usual guidance documents on infection prevention and control or guidance for personal protective equipment, but people tasked with providing these guidance had to start even naming them. So you see, for instance, that we had the rational use of personal protective equipment in the care of COVID-19 patients. If you look at the picture here, this was sent to us from one of the states in Nigeria as part of COVID-19 response activity. And you can already see that this is really a very inappropriate use of this personal protective equipment, which is the coverall, which at that time and even now was quite expensive. And even what is going on here, I can't even tell. Some kind of fumigation, which really is more for control of vector control. But you can see that all these things were the things that we found out that were contributing to the pressure and resulting in the global shortage. I would walk us through a simple cost analysis of the implications of inappropriate, excessive use of personal protective equipment and the consequences for an already under-resourced and already overburdened health system, a health system where basic amenities are already missing. And then you add on to that the inappropriate, often excessive use of personal protective equipment. So I just got this off the internet. Some costing, some price list, I think it's a South African price list of COVID-19 personal protective equipment. So if you look at the area here, just to draw attention to the cost of the surgical mask for health worker use and the cost of a respirator or an FFP2, which we know from what Prof presented earlier, that there are different recommendations or conditions of use. Now, for the surgical mask, for the box of 50 pieces, when you work it out, it costs about 12 Rand, 12.5 Rand per mask. And then for the N95 respirator, it is around, call it 38 Rand approximately. Just comparing these two costs, one can see that an N95 respirator is approximately 3 times the cost of a surgical mask. And therefore, each time a health worker inappropriately uses a surgical mask for a situation where uses an N95 mask for a situation that a surgical mask will adequately protect, such a health worker is spending 3 times what should be spent for that particular activity. And you know, there's always an opportunity cost for everything. So each time that happens, money is being taken away from the system to fund this very unnecessary use of face mask. Then we look at the gowns versus the coverall. Just wanted to show these 2 examples. If you look at the cost of the gown, the surgical gown, the non-woven, basically the disposable gown, it costs about 135 Rand for one. But then for the coverall from this price list, we see that it's about 286 Rand. So the gowns compared to the coverall costs approximately 2 times what it costs to buy the gown is what it costs to get the coverall. And one thing that we must bear in mind is that this doesn't happen in isolation. There are other costs that also need to be incurred. There's the cost of disposing the coverall. There's the cost of other items that are worn in combination with the coverall. And the tendency is that if somebody will inappropriately use a coverall, the person will most likely inappropriately use an N95 and would also inappropriately, I suspect, use other pieces of personal protective equipment. So when all these things add up, it removes money, I suspect, from other important aspects of infection prevention and control, the administrative controls, and even some environmental and engineering controls, because this is the visible part. The PPE is the visible part, and often this also can result in what is called the purity ritual and give people the impression that they are protected when really they may not be fully protected because of other factors that may be in operation. This shortage and the pressure and everything going on around personal protective equipment really is a big problem. And you can see, these are just newspaper and what was going on in the news in 2020. So you see Africa CDC warns of possible acute shortage of COVID-19 protective equipment in Africa. In UK, we had this BBC headline that said doctors told not to discuss PPE shortage. And the one from South Africa saying South Africa's COVID-19 PPE shortage is being addressed. So indeed, personal protective equipment, both the proper and irrational use and the supply and logistic issues, they are really a big problem. And these are issues we need to discuss and we need to manage because they're very critical for keeping health workers safe. So we'll now look at some of the strategies that we can employ to increase the proper use of personal protective equipment, including the availability and making these things available in the right combination, the right quantity in combating COVID-19. And one of the ways really is increasing manufacturing capacity. Yes, there's irrational use and there may be inappropriate use, but one thing that is evident is that even before the pandemic, most African countries lacked the PPEs that were needed for even routine care. So at a time like this, it provides the opportunity for increasing manufacturing capacity. And one of the ways of doing that is to get private sector involvement. And for instance, in our country, Nigeria, private sector really got involved. And so you see private sector getting involved in the production of surgical masks. You see private sector getting involved in the production of some gowns, aprons, and what have you. So this is one of the ways that we can increase manufacturing capacity. And this is a sustainable way that we can continue with post the pandemic. Then there's the rational use of PPE based on service delivery activities and assessment of risk of infection. As has been discussed, PPE is not just used because it is prescribed that once you see a patient, you need to put this combination and see each and every patient. There's some kind of risk assessment that goes on that informs the selection of personal protective equipment. So you see situations where we may have to reserve respirators for aerosol generating procedures. And also not forgetting that even though we are primarily engaged with COVID right now, there are still other airborne transmitted disease risks, such as tuberculosis, the chickenpox, and based on risk assessment, when we are working with such patients, we still have to use the appropriate personal protective equipment. And one other issue that we have to be mindful and deal with is misinformation and enhanced monitoring for negative impacts. We have to be mindful and watchful to understand what is driving this over demand for personal protective equipment. It could be, and this can result in health workers not realizing that they may be getting infected in community and not paying attention to things going on in community simply because they have put everything on personal protective equipment at work. All these things can lead to unnecessary stock out from the market and may create anxiety among the population. Appropriate training. Appropriate training is really crucial for health workers, especially in the area of how to apply risk assessment in the selection and in the use of personal protective equipment. But then one thing is to know the personal protective equipment to use for different patient encounters, but it is even more important to understand how to put them on and how to remove them safely, and how to make sure that such PPE do not pose a hazard to other people in the health facility and in the community in the form of waste. So this training is critical, and it is also through training that we can address issues around the wrong use of PPE, correct misconceptions, and all the issues around the purity, ritual, and what have you. And these trainings really should be hands-on as much as possible. Such trainings should be participatory. And such trainings must also begin to understand that we are dealing with behavioral change issues. And therefore, we mustn't discountenance people's views around this issue, but we must explore them together and design appropriate training to address the underlying and the fundamentals. Then we must look at issues around the coordination of the personal protective equipment supply chain management mechanisms in place. Countries such as Nigeria are expected to maintain a national personal protective equipment strategic stockpile for the surge demand of personal protective equipment in the early stages of a pandemic. And indeed, a country like Nigeria has always maintained that national stockpile. But for practical purposes, you notice that such strategic stockpiles have to deal with issues such as storage fees, cost of warehousing, and then expiration issues. Some stay in the warehouse and then they expire. So all these things would really have implications for how effective these strategic stockpiles are when you finally have a pandemic, such as we have now for COVID-19. And therefore, both at national and at subnational level, we must strengthen the capacity to maintain and distribute these stockpile. Some people have recommended a 3-tier stockpiling framework where you must be clear what's the national stockpile for. Are there some diseases that we consider very important that we must have these stockpiles for? Same for stockpiling at subnational level, and every facility, health facility, must also do their own risk assessment and make some provisions for their health facility level PPE stockpiling. Even though when a pandemic such as this comes, it does put the stockpiling under stress. But we can imagine if there's no planning for stockpiling and there's planning for stockpiling and it puts pressure, then we can just see how bad it would have been or will be if there's no such coordination and planning. And then there must be a mechanism for coordinating through an essential national and international supply chain management mechanism. And this was one of the places where the Africa CDC played a key and critical role at the early phases of this COVID-19 pandemic and supported a lot of states, a lot of member states in meeting or filling the gap in their PPE supply chain. Another thing that also must be in place is PPE forecasting based on rational quantification models that will ensure the rationalization of requested supply. So it's not enough to have the supply chain. We must make sure that the fundamentals are right, that what is informing the quantification is rational and is based on use, the utilization pattern at facility level, at state level, at national level. All these things are very critical. And then there's the monitoring. We must monitor how these PPEs are distributed from end to end, down to the last mile. We must have data because it is data that will drive everything. So there has to be the monitoring from end to end distribution of the PPE. and also the controlling of this distribution mechanism. So you notice that I will share the Nigerian example. To enable the efficiency of the national supply chain, the Nigeria Center for Disease Control uses what we call a logistics management system, LOMIS. And this is a digital system that tracks supplies at national and state level. And what this has done is that it has helped stock out and also helped us in improving preparedness. And between February and December 2020, the NCDC has actually deployed nearly 3 million pieces of personal protective equipment through this logistics management system. And I would like to conclude by saying that really the key to proper use of PPE, and by proper use, it starts from making it available through training, checking, though everything that's been discussed around the multimodal strategy can happen at any level, national, subnational, state level. The key is to build a resilient system that is capable of withstanding, adapting to, and recovering from disruption. Healthcare-associated infections are happening every day. Before the COVID pandemic and will continue after the COVID pandemic. And it is a proper system in place for infection prevention and control, of which appropriate use of personal protective equipment is one of them. So it is only a resilient health system that will see us through a pandemic, prevent the next pandemic, and still control other healthcare-associated infections, including the control of antimicrobial resistance. And it is only a resilient health system that can continue to meet supply needs of personal protective equipment. And in the case of a pandemic, a resilient system can help raise production as the need arises, because pandemic puts extra pressure, and it is only a pandemic a resilient system that can increase production to meet this demand and be able to revert back to meeting routine utilization patterns. So these are the points I want to conclude with, and thank you very much for your attention.
Thank you, Dr. Tochi, for that informative session. Our next speaker, I'm going to invite Dr. Kase, who is a consultant infectious disease physician and is the head of the Lagos University Teaching Hospital. He is here to give us the country experience on what they have done with regards to ensuring that healthcare workers use PPE appropriately. Dr. Kase, over to you. Thank you.
Thank you very much, Lizzie. It's an honor to be here to share our experience with everyone. I'll just use some of the principles that have been shared by both Professor Shola and Dr. Tochi to just explain how we have been able to handle our challenges with the use of PPE. Lagos University Hospital is a tertiary institution in the center of Lagos. Lagos is the most populous city in Nigeria, population of 20 million or more. There are problems with overcrowding, and it's the epicenter of COVID in the country. But naturally, Lagos had to respond appropriately when COVID came, and so the hospital management dedicated a 120-bed facility, which was, a general ward before, that was converted to a COVID-19 facility. We started admitting patients 7th April 2020. So far, we've managed over 850 patients, including many specialties like surgery, gynecology, pediatrics, across all the fields of medicine, as you would expect. We delivered 14 women, one of which was a set of twins. So it just gives us a picture of not only the core group of people who are in the infectious disease unit and IPC team as the work with us, but also including other specialties that have come to review patients and go. So as you can imagine, there was a lot of challenges around both those volunteers who were with us initially, but also people who are not primarily infectious disease people, who just come to review patients like surgeons or cardiologists or something to review patients and go away. So we had challenges around PPE use. Most of the people that came, even the volunteers that came to join us, were naturally very apprehensive. Once you invite someone to come review a patient, they ask you, you must give me this PPE, you must give me the full suit, and so on and so forth. All kinds of requests were being made because we were apprehensive about being infected. And so many people were unwilling to go into the wards. With that, even when they accepted to go, they will not go unless you assure them or provide for them all kinds of protection. And it didn't help much that we had videos from China at the beginning circulating of people wearing like 3 or 4 sets of PPEs before going into the ward. And so people use that kind of video to expect that that's what will happen when they were about to go into the ward. But patients needed to be cared for. So naturally, we had to acquiesce to some of these demands and provide as much PPEs as they needed to be confident enough to go inside the ward and see patients. So the initial set of PPEs that was supplied to us and that we got both from the CDC and the hospital management and Lagos State were essentially the full-length PPEs as we saw in the picture that Professor Gwichula showed earlier on. In fact, that picture he showed was what was going on for the first 1 or 2 months, if I even up to the 3rd month of our work with patients. And it's pertinent to know that at that time, once somebody goes in there, everything was discarded, including the N95 and the full-length PPEs and all of that were discarded after every single use to be destroyed. So you can imagine for months, this was a practice that was going on in our. So this is a picture of a healthcare worker who was going into the isolation ward to see a patient. You can see him fully kitted up with full-length gown, including things we had with this scenario we had was that these suits were very uncomfortable. Staff couldn't use them for long. And then when emergencies arose in the wards where staff needed to go in, the time it took for people to go and first get the PPEs, come and put them on and before they go in, and the fact that it was a one-use thing, so there were delays and a lot of inertia in going to the wards to attend to patients that had challenges or required staff care in the wards. So, and what this amounted to was that there was suboptimal care of patients. There was suboptimal care of patients because staff couldn't stay too long in the ward to provide care for the patients. Also, the response time was also quite long before people could go into the ward. So that we saw there was a lot of needless mobility and as well mortalities, I must say, is because of the inappropriate use of PPEs. Additionally, of course, after a few weeks, we ran out of our supplies of both the suits and the N95s, and so we started, some staff refused to go into the ward unless they had all of that. So it definitely became a sort of a crisis with us. It became a sort of a crisis with us because of this scenario. Okay, so now, so what did we do to overcome these challenges? We realized, we discussed this with various stakeholders, and we realized that it's important for us to keep providing the right training to the people, giving them the right information, reassuring them, because without them getting that knowledge, they were not going to follow us, and patient care was going to suffer. So we kept providing the training. And I will also explain to them difficulties around, like Dr. Chuchi has said, around issues around supply chain. We told them that, you know what, if we finish these PPEs now, we're not sure we're going to get any other PPEs in the time to come. And unfortunately, at that time, we're having lots of our colleagues and our relations who were coming to be admitted onto the ward. And we told them, you know what, if you don't use these PPEs well, you're unable to take care of your colleagues who are on the ward. You're unable to take care of your relations who are on the ward. So they are going to suffer because we don't use the PPEs well. So when we painted the picture of the challenges and we put up before them the science that shows that you really don't need all of this PPE, to do that. So it was a process, provide the right training, but also explain to them. Because if you don't do that, a lot of people are going to react more emotionally and they're going to abandon you and run away. So we took time to do that. And we also led from the front. So I been the team lead and as well as the other leaders in the team. They saw us using this other PPE, the right PPEs, going into the ward. And they saw after a few weeks, they didn't see anybody falling sick and they didn't see anything happening. So a lot of confidence began to, we started instilling confidence in the team over time. At the moment, this is one of the nurses that works with us. This is how over time, of course, they realized the need to both downgrade and use the appropriate PPEs for patient care. And we also started using some modalities around reusing some of the PPEs as appropriate. So this is a picture of one of the staff who is in the ward trying to take care of patients. She's wearing her scrubs with her work shoes, her scrub shoes. She has on the surgical gown which can be reused, and a surgical mask, and also a face shield, and she can stay long in the ward. This doesn't take time to put on, and she can, take care of patients, provide the right care, and it's not so expensive to procure. And with the reuse and reuse, in fact, we have not had any issue with supplies of PPEs for months now, to be honest, because of course, naturally, there's always need to get but with the right manage things appropriately, so much so that now uh, we have overcome the challenges around that, and our patient care has improved markedly because we're able to respond appropriately and in short time when patients come. Additionally, staff confidence went up remarkably because we saw that over the past, from April to now, we managed 112 healthcare workers from the hospital and elsewhere, not necessarily those working with us, but who are the other aspects, who are the other parts of the hospital. The hospital is not just the COVID center, there's a surgery, there's medicine, there's all those specialties you can think of. Also, staff that were infected and came out of these 112 healthcare workers. Prior to this second wave, Nigeria is in the second wave now that started in December, and it's about going down. It's just started on downward trend now. Prior to the second wave, we had only one response member who was infected by COVID. And that really gave a lot of confidence among the team that, oh, you mean we can use this, less PPE, but still not be infected. And, this created lots of confidence in the team, a lot of knowledge was created. And so this helped do that. Of course, in the second wave, we've had a little more numbers infected because staff are now going home and coming back. We're unable to create a bubble we're able to create in the first wave because naturally we needed more hands and communities opening up and all of that. So now we've had 6 more members infected in the second wave, but still way less than what we're still seeing in the other, in the general hospital and the other forms of healthcare workers who are not part of the team. So it is clear that downgrading or using the right PPEs did not necessarily put them at increased risk. In fact, it helped them to provide better care and also made them more comfortable providing the care that they needed. We conserved resources. We're having less stockouts, way less stockouts than what we had back when we first started. Our patient care has markedly improved. We're able to, respond quickly. We spend more time in the ward, and patients have, have also testified to the fact that they feel quite so. So, in conclusion, we've seen from my experience really that if you raise the right PPEs, it improves patient care, but also it promotes staff confidence, reduces, it takes away misinformation, gives them the right information, and it can also experience for themselves that, using the right PPE is the right thing to do. We know that not only is disproportionate PPE use, not only is it too expensive. I saw clearly, we've seen the picture painted of how it's more expensive and more damaging to the supply chain generally. But also, even for patient care, it is counterproductive because one, the patients don't get the best care, and the staff don't enjoy what they are doing. Because I mean, for those of us who have worn those full-length PPEs, you can see how uncomfortable it can be after a few minutes. So it's really counterproductive when you don't need to dress that much and you put on all of that. But it is also very important to realize that staff, especially those who are working with you, that need to be carried along. You can't just expect them to just force them to do something. You must carry them along, give them the right information so that you can create the necessary environment for them to accept change. So thank you very much for this opportunity to present. Over to you, Lisa.
Thank you, Dr. Kase. And now I'm going to call our last speaker for the day, Mr. Felix Ingambire, who is a public health specialist and works in the logistic and supply chain pillar in African CDC. And she's going to give us a perspective on the PPE supplies. Thank you, and over to you, Mr. Felix.
Thank you very much, and it's a pleasure to speak after Dr. Fulesad, Professor Fulesad, Dr. Tochi, and Dr. Kase. I think they touched base on the technical aspects of supply chain management, and I will quickly take you through the experience on this area of supply chain management of PPE for COVID-19 response. So first, Africa CDC supports African Union member states in COVID-19 response activities. There are many areas Africa CDC supports member states, namely enhancing capacity for laboratory testing and genome sequencing, supporting surveillance and points of entry screening, IPC, risk communication, case management, but most importantly, support member states to consistently have COVID-19 medical supplies, including PPE. And just for information, Africa CDC or the African has five regions, namely Eastern, Western, Central, Southern, and Northern regions, with 55 member states. And Africa CDC has always worked to support all these countries in COVID-19 response. Now, what about supply chain management? As many speakers talked about it, we've done the normal functions of supply chain management. When the COVID-19 hit Africa early 2020, the first thing we did was selection of products that may be required by member states. Then if we forecasted demand, we made procurement, warehousing, storing, managed inventory. Then we shipped and transported these materials to different countries and different places. And now we continue to manage the data about what has been shipped. Briefly, these are the core functions that a normal supply chain management consists of. And it's captured in the figure that you can see. For the sake of time, I move quickly. So as previous speakers touched about that, there were many challenges. There was supply shortage, there was segregation of supply, and that was just third capacity is allowed, and logistics were a problem. Then the demand was higher than the supply, and every country wanted to secure their supplies. There was a problem with quality because the new entrants into the supply market were not guaranteeing the quality that was expected. There was that diplomacy of supplies where countries were leveraging on their bilateral engagement with their suppliers to secure more supplies. But also there was restrictions on exports. There were restrictions on exports, so it was sometimes difficult to get supplies from some countries. And as previous speakers said, some manufacturers tried to repurpose, and there were also kind of an emergency use authorization for some products so that the market can get some of the supplies, including the PPE. So these are the international challenges that we faced at the outset of the pandemic, and some of them are still continuing to be observed currently. So some other challenges were COVID-19 was a new disease. And when you want to do quantifications, it was quite difficult to make quantifications assumptions. There are some models that were available, but they were kind of ill-defined. The low testing capacity of countries could not allow proper quantification. And as I said, low supply combined with low visibility at national level, because at Africa CDC wanted to compile and consolidate needs for all countries, but the visibility at national level was a problem. There were other challenges on procurement side. Africa is a net importer of PPE and other medical commodities. There were financial constraints, and there are many other challenges. But on the logistics part, even when the supplies were secured, there are issues with moving the logistics from a point to another because of the lockdown that imposed at the outset of the pandemic. So what we did at Africa CDC is that we established firsthand Africa Task Force for Coronavirus, and this task force has been leading the efforts. So the ministers of transport and logistics have met and agreed to have some corridors to allow transportations of both supplies and people. Then there was a supply chain technology group that was formed to coordinate and resolve supply-related issues. Secondly, we launched the PACT, the Partnership for Accelerated COVID Testing. This has helped Africa CDC to Then very, very critically, we launched the Africa Medical Supplies Platform, which is a digital platform to help in
I think we seem to have lost Felix. Hello, Dr. Wande.
Hi, Lizzie.
I think
it looks like we've lost him. So I think we've got a few more minutes. Maybe what we can try to do is take a couple of questions. I see that we have a good number of our colleagues on the call today. So I think we can take a few questions. Let me just try to see. I see that Prof has dropped off. There are quite a number of questions for her, but I'm happy to just direct some questions to Dr. Tochi and other colleagues on the call. So I think one of them is around coveralls and using them in BSL 2 or 3 laboratories for COVID-19 during extraction of RNA. I think the person wants to know if coveralls are necessary. Dr. Tochi, if you're happy to talk a bit about that. I see Elizabeth Bancroft too on the call, and I saw a couple of colleagues from EMRO earlier.
Yeah, okay, thank you, Wande, for that. Can you repeat that question so that I'm clear about it, please?
Yeah, it's the question is around use of coveralls in BSL-2 or BSL-3 laboratories during extraction of RNA. The person just wants to know if we're recommending that.
Thank you very much. For when we say BSL level 2 and BSL level 3 already, it implies what level of pathogen you're dealing with. A BSL level 3 should already have some things that go with it that is standard for you to wear. And I'll suspect that what is even more important at that point is the respiratory protection and to avoid the contamination of the sample. So if there's an absolute need to wear, for BSL level 2, I wouldn't think so. But for BSL level 3, to wear the coverall, really, if there's the availability of that coverall, but I suspect that that may not be absolutely necessary. Over. But colleagues, I'll really defer to other colleagues here to say what the experience has been, because I'm not a completely lab person.
Thank you so much, Tochi, for that. Professor Val, Elizabeth, I see you on the call. Feel free to jump in if you have any response to that. I'm also trying to see how to pull questions that could be potentially beneficial. Dr. Akese, I see a question for you. I will be coming back to that.
Hi, this is Elizabeth from CDC. And I, like Prof. Tochi, am not a specialist in labs. That being said, you have to think about why a coverall would be used. It would either be used, as Dr. Tochi mentioned, to reduce contamination of the specimen from the person, which I don't think is as much of a consideration when we're looking for COVID or other bugs. And then the other is coveralls are really used when you think that the person can get contamination or get infected with a pathogen anywhere on their body. So that makes sense, for example, with Ebola, where, you know, even small cuts can be contaminated and you can get ill. I think for the terms of COVID, the real key thing is still that respiratory protection level and the hands to be covered well and using hand hygiene, because those are the ways you're going to get COVID into your system. You're not going to get it if it falls on your leg or falls on your arm, you know, particularly, but you're going to get it if you get it in your hands and then put your hands up to your mouth, or if you aren't wearing a mask properly, like a well-fitted mask properly. Over.
Okay, fantastic. Thank you so much, Elizabeth and Tochi. Felix, I see that you are back on, and if you have just a few slides to share, I think it's okay for you to try to wrap up your presentation if your network is good. Thank you, Felix. Just to let you know that we have a few more minutes, so you might want to summarize your slides. Thank you.
Yes, so part of the solutions we provided to the challenges we faced is the creation of Africa Medical Supplies Platform, which is a network that made supply chain simpler. It helped vetting global manufacturers, aggregating demand, quota management, payment facilitation, and logistics support. And on the next slide, there is a link where if people may could visit and countries and other NGOs can register and start making their procurement through the platform. And we, as the previous speakers said, we mapped out and engaged manufacturers of PPE in the world, especially on the African continent. And we consistently at Africa CDC provided PPE to African Union staff and also to member states to make sure healthcare workers are protected in Africa. So these are the categories of things we distributed: surgical masks, gloves, N95 masks, and etc. And the map here shows what we distributed to the countries. There are many. There was a set of parameters considered while making quotas for countries, where the population of a country was the chief of those parameters. And as you can see on the map, the darker, the more PPE received by countries. And here, I think Nigeria, in the darker color, has received more of the PPE, considering the population there. And now we are working on availing vaccines. We are trying to vaccinate 40% of the African population by end of this year and 60% by next year. So here the slide is that we need also to make PPE and other ancillary products available for the effective deployment and mass vaccination against COVID. And it's very important, as previously emphasized, to properly use PPE and adhere to the other IPC measures. So the key takeaway here is we need to protect healthcare workers by availing PPE and properly use them. And we continue with the other IPC measures. I thank you very much.
Thank you very much, Felix. Thank you very much to all the speakers that have joined us today. Unfortunately, we will not be able to do our usual interactive Q&A because we are running out of time. But what our team would do is collate most of the questions that we have that you have submitted, and we will try to answer it by sending them to you on the community of practice. But that said, we will also try to ensure that next week we save additional time, hopefully maybe 40 minutes of extensive Q&A discussions next week. So please, if there are certain questions you really wanted us to answer, and because of time we couldn't answer it today, please save your questions. We will definitely take it on next week. On that note, I would just like to thank all of the speakers. Thank you for making time to be a part of our weekly webinars. Thank you to all the experts who serve on the panel. Unfortunately, we didn't have time for a longer discussion, but next week is another time. Also, thank you to the interpreters for providing technical assistance to this meeting. So we will speak to you next week. We look forward to an exciting discussion. Same time, 1 p.m. Eastern African time on Wednesday. We look forward to meeting you next week. Thank you and goodbye.
Thank you. Goodbye.
Thank you.
Thank you. Bye-bye.